Good morning, everyone. I am Dr. LYDIA SAJU, and today we'll be continuing with our journey through Section 7 of Reading Club based on Misch Contemporary Implant Dentistry. Chapter 37, Maxillary Sinus Anatomy, Pathology, and Graft Surgery. Maxillary sinus anatomical variants. Numerous anatomic variants arise that can predispose a patient to post-surgical complications. When these conditions are noted, a pharmacologic protocol may need to be altered and/or implants may be placed after the sinus graft has matured rather than predisposing them to an increased risk by inserting them at the same time as sinus graft. As stated previously, patency of the ostium is paramount to maintain drainage. Pre-existing skeletal and bony abnormalities of the osteomeatal complex may compromise the patency of the maxillary ostium, thereby predisposing patients to maxillary rhinosinusitis. Miscellaneous factors that affect the health of the maxillary sinus. Smoking. The use of tobacco is one of the main factors that may lead to an increased morbidity after sinus graft procedures. Smoking is known to be associated with an increased susceptibility to allergies and infections because it interferes with ciliary function and secretory immunity of the nasorespiratory tract. In the maxillary sinus, this may have direct effects on both immune exclusion and suppression because IgA and IgM responses are reduced, whereas IgE responses are increased. Smoking is believed to interfere with bone graft healing because it reduces local blood flow by increasing peripheral resistance and causing an increased platelet aggregation. Byproduct chemicals of smoking, such as hydrogen cyanide and carbon monoxide, have been shown to inhibit wound healing, as does nicotine, which inhibits cellular proliferation. Tobacco may interfere directly with osteoblastic function, and strong evidence exists of decreased bone formation in smokers. In addition, smokers have a significant reduction of bone mineral content. Bone mineral density can be reduced 2 to 6 times in a chronic smoker. Overall, smoking may contribute to poor available bone quality and poor healing capacity resulting from vascular and osteoblastic dysfunction. There exist many clinical studies with smoking and sinus graft procedures. Cloquepole evaluated the success rate of dental implants placed in the posterior maxilla. It showed a 7% greater fail rate compared with non-smokers. Lindquist showed that smokers can also suffer detrimental effects around successfully integrated maxillary implants with a significantly greater bleeding index, greater mean peri-implant pocket depth, more frequent peri-implant inflammation, and radiographically greater mesial and distal bone loss. Olson and colleagues found an association between dental implants placed in augmented maxillary sinus and history of smoking. Widmark reported a higher failure rate in smokers after rehabilitation of severely resorbed maxillae with and without bone graft. Schwartz, Arad and colleagues evaluated 212 implants in the posterior maxilla, resulting in a 95.5% success rate with 9 failures. Of the 9 failures, 5 were in patients that smoked. In summary, smoking is not an absolute contraindication for sinus graft procedures. However, patients should be instructed to cease smoking before and after sinus graft procedures because of the literature-based studies showing a higher risk of bone dehiscence, graft infection and/or resorption, and a reduced probability of osseointegration. It is recommended, however, that if a decision to proceed with surgery has been made, then patients refrain from smoking at least 15 days before surgery, that is the time it takes for nicotine to clear systemically, and 4 to 6 weeks after surgery. Moreover, smokers should sign a detailed informed consent in which risks connected to smoking are clearly defined and explained. Relative and absolute contraindication to maxillary graft procedures. In general, contraindications for implant surgery also apply to sinus graft procedures. However, additional specific and local conditions may exist that increase morbidity. Several conditions related to the maxillary sinus are a concern, but they are not necessarily contraindications to the sinus graft procedure. The implant clinician, after evaluation of the CBCT scan and evaluation of the maxillary sinus, will in some cases need further medical evaluation before proceeding with procedures that may invade the sinus proper. There exists a wide variation in the severity of possible pathologic conditions that may be present in the maxillary sinus. For example, a patient may have a mild deviated septum. Because it does not affect the mucociliary clearance of the maxillary sinus and there is no associated pathology, no medical consultation by an ENT is warranted. Absolute versus relative contraindications. Relative contraindication. Limited anatomic or structural impairments of the sinus or nasal walls that are correctable. Inflammatory or infectious processes that are treatable. Foreign bodies. Oroantral fistulas. Absolute contraindications. Anatomic or structural impairments of the sinus or nasal walls that are non-correctable. Inflammatory or infectious processes that cannot be resolved, that is, chronic rhinosinusitis. Fungal or granulomatous diseases of the nasosinus. Benign or malignant neoplasms of the nasosinus. Medical consultation, otolaryngologist. No referral. Mild mucosal thickening, small cyst that is less than 8 mm, history of mild sinusitis with no radiographic evidence of pathology. Referral recommendation, air fluid level, cyst greater than 8 mm, primary or secondary mucocele, polyps, opacified sinus, chronic sinusitis, bony wall expansion or destruction, previous trauma, foreign body in sinus, early learning curve. Reduction of sinus graft complications. Even though sinus graft procedures have high success rates, these procedures tend to have a higher risk of infection than implant placement surgery because the patient is predisposed to infections originating from the oral surgical procedure, that is intraoral infection originating from the surgical site, or from the sinus graft procedure, that is infection within the sinus proper. Therefore, a surgical environment that includes a strict aseptic technique including intraoral and extraoral scrubbing with chlorhexidine, scrubbing and draping the patient, and gowning of the doctor and assistant should be considered in addition to sterile gloves and sterile instruments. The risk of postoperative sinus infection is generally less than 5% when these procedures and a preoperative and postoperative pharmacologic regimen is used. Prophylactic medications. Systemic antimicrobial medications. The risk of bacterial contamination before and after sinus graft procedures are much different than routine implant surgical procedures. Therefore, the pharmacologic protocol for sinus graft procedures should be effective against the organisms in this surgical site. The recommended pharmacologic regimen includes the prophylactic antibiotic, anti-inflammatory medications, and antimicrobial rinses. Compared with routine dental implant surgery, sinus augmentation has a greater chance of morbidity because of the possible additional routes of infection. Bacterial infection may originate from different sources such as intraoral surgery, bone graft material, and bacteria from the sinus cavity. Additionally, it has been well documented that the inclusion of foreign bodies increases infection rates. Because a greater chance of infection and morbidity exist with this type of surgical procedure, a strict antibiotic protocol is of benefit. Antibiotic medications have been shown to significantly reduce the number of sinus graft or implant failures caused by infection. When evaluating various classes of antibiotic medications used for treatment of maxillary sinus infections, the antibiotic class of choice is the beta-lactam antibiotic drugs. With the wide range of possible routes of bacterial invasion and types of bacteria, the antibiotic drug must be broad spectrum to account for all these possibilities. However, bacterial resistance has become a significant problem in the treatment of these pathogens. Bacterial resistance is initiated by two common mechanisms: production of antibiotic inactivating enzymes in Staphylococcus aureus, Haemophilus influenzae, and Moraxella catarrhalis, and alteration in the target site, Streptococcus pneumoniae. Studies have shown that following resistance, that is beta-lactamase production, it results in H. influenza 36.8%, M. catarrhalis 98%, and S. pneumoniae 28.6%. Because of the high rate of bacterial resistance, amoxicillin, the drug of choice for many years, is no longer recommended for antibiotic prophylaxis for the sinus graft surgery. Instead, amoxicillin clavulanate, that is augmentin, is used because the addition of clavulanic acid enhances amoxicillin's activity against the beta-lactamase producing strains of bacteria. Iodophor compounds, that is betadine, are a most effective antiseptic. However, because the iodine is complexed with organic surface active agents, it has been shown to inhibit the osteoinduction of allograft bone. Therefore, the use of 0.12% Chlorhexidine gluconate, Peridex scrub, and rinse is most often used as intraoral preparation of the surgical site requiring a bone graft. Extraoral pre-surgical scrubbing of the skin should also be performed with chlorhexidine antiseptics prior to surgery. Surgical treatment of the maxillary sinus, the history. In the early 1970s, Tatum began to augment the posterior maxilla with autogenous rib bone to produce adequate vertical bone for implant support. He found that onlay grafts below the existing alveolar crust would decrease the posterior intradental height significantly, yet very little bone for endosteal implants would be gained. Therefore, in 1974, Tatum developed a modified Calwell-Luke procedure for sinus augmentation grafting. The crest of the maxilla was infractured to elevate the maxillary sinus membrane. Autogenous bone was then added in the area previously occupied by the inferior third of the sinus. Endosteal implants were inserted in this grafted bone after approximately 6 months. Implants were then loaded with final prosthesis after an additional 6 months. In 1975, Tatum developed a lateral approach surgical technique to elevate the sinus membrane and place implants simultaneously. The implant system used was a one-piece ceramic implant, and a per-mucosal post was required during the healing period. Early ceramic implants were not designed adequately for this procedure, and results with the technique were unpredictable. In 1981, Tatum developed a submerged titanium implant for use in the posterior maxilla and achieved predictable results. From 1974 to 1979, the primary graft material for sinus graft was autologous bone. In 1980, Tatum further expanded the application of SA augmentation technique with the lateral maxillary approach and the use of synthetic bone. The same year, Boyne and James first reported on the sinus graft technique using autogenous bone for SA grafts. Most of the publications in the 1980s were anecdotal or based on very small sample sizes. Treatment classifications for the posterior maxilla. In 1984, Misch organized a treatment approach to the posterior maxilla based on the amount of bone below the antrum, and in 1986, he expanded the treatment approach to include available bone width that was related to implant design. In 1987, Misch included the technique of the sinus floor elevation through the implant osteotomy before implant placement. He reported on 170 sinus graft cases with 2 complications and an uneventful resolution. In the Misch SA classification, the treatment modality is dependent on the available bone height between the floor of the antrum and the crest of the residual ridge in the region of the ideal implant locations. The SA protocol also suggested a surgical approach, bone graft material, and a timetable for healing before prosthetic reconstruction. In 1995, Misch modified his 1987 classifications to include the lateral dimension of the sinus cavity. This dimension was used to modify the healing period protocol because smaller width sinuses, that is from 0 to 10 mm, form bone faster than larger width, that is greater than 15 mm sinuses. The division A width range was also increased to 6 mm to permit more bone to encompass the implant on each side. In 2017, Resnick modified the Misch classification to include alternative treatment options with short implants, crustal grafting approaches, and treatment plan modifications based on force-related factors. Surgical technique. Subantral option 1, conventional implant placement. The first Misch SA treatment option, or SA1, occurs when sufficient bone height is available to permit the placement of endosteal implants following the usual surgical protocol with no maxillary sinus involvement. Because the quality of bone in the posterior maxilla often is D3 or D4 bone compaction or osteodensification to prepare the implant site is common. This technique permits a more rigid initial insertion of the implant and also increases the BIC. Required bone dimension. In the abundant bone volume, division A, the minimum ideal bone height for the SA1 is related to the associated force factors. Under favorable conditions, a minimum of 8 mm of bone is required from the crest of the ridge to the inferior floor of the sinus for the placement of an 8 mm implant. The literature has concluded that short implants, that is 8 mm implants, have been shown to be successful in the posterior maxilla. If multiple implants are placed, then ideally the implants should be splinted for forced distribution. For unfavorable conditions, greater than 10 mm of bone is required in height to allow for placement of an implant so it does not invade the maxillary sinus. This will allow an implant of 10 mm in length to be placed that will allow for greater insertion torque and BIC. Therefore, the implant will be less likely to have a force-related effects that may cause micromovement during the healing phase and poorer healing. Subantral option 2, sinus lift and simultaneous implant placement. The second SA option in the Misch SA classification, SA2, is selected when the intended implant length is 1 to 2 mm greater than the vertical bone present. In this technique, 1 to 2 mm may be achieved via elevating the sinus membrane without bone grafting. Tatum originally developed this technique in 1970 and Misch first published it in 1987. Summers published a similar procedure in 1994, 24 years after Tatum's first presentation. Because the SA2 surgical approach modifies the floor of the maxillary sinus, a pre-existing pathologic condition of the sinus should not be present because it may affect the implant site by retrograde infection. This technique is reserved for 8 to 10 mm of host bone below the sinus, in which an implant is placed via an osteotome technique that elevates the membrane approximately 1 to 2 mm with the use of no grafting. Ideally, an 8 mm implant is used with caution in these cases. Complications. If a sinus membrane perforation occurred during the initial implant placement procedure, then bone height growth is less likely to occur. This is the primary reason why only 0 to 2 mm of additional bone height is attempted with this technique. However, even when membrane perforation occurs and or no bone grows around the apical end of the implant, the SA2 technique is of benefit because the apical end of the implant is surrounded by denser bone. This enhances rigid fixation during healing and increases BIC, leading to improved loading conditions. If inadequate bone is formed around the apical portion of an implant, then a progressive loading protocol for D4 bone is suggested during prosthetic reconstruction. Subantral option 3, sinus graft with immediate endosteal implant placement. The third approach to maxillary posterior edentulous region, SA3, is indicated when at least 5 mm of vertical bone and sufficient width are present between the antral floor and the crest of the residual ridge in the area of the intended prosthesis abutment. A residual height of 5 mm for the SA3 category has been selected for two main reasons. 1. The height, inadequate bone width and quality can be considered sufficient to allow primary stability of implants placed at the same time as the sinus graft procedure. 2. Because of the amount of residual bone, 5 mm, greater blood supply is present, which allows for more predictable and faster healing. Surgical approaches. There exist two options for grafting the sinus along with simultaneous implant placement. Lateral wall. A Tatum lateral maxillary wall approach is performed by performing an osteotomy over the lateral wall of the maxillary sinus, in fracturing the window, elevating the sinus membrane and window, grafting to the medial wall, and then placing the implant. Sinus graft layered approach. Top layer, collagen and antibiotic. A resorbable collagen membrane or a tape soaked with a parenteral form of antibiotic and 0.2 ml is then prepared. Sinus graft layer technique in the top layer, superior layer, collagen membrane and local antibiotic, middle layer, intermediate, 70% mineralized freeze-dried bone allograft, 30% demineralized freeze-dried bone allograft, platelet-rich fibrin from 10 ml of whole blood, antibiotic, then at the bottom layer, autogenous bone tuberosity. The collagen and antibiotic are placed onto the elevated antral floor region and attached to sinus mucosa on the superior part of the graft site. The collagen is a carrier for the antibiotic to decrease the risk of post-operative infection. In addition, in case of membrane tearing or separation of the sinus mucosa, with or without the awareness of the clinician, the collagen membrane seals the opening. It is imperative that a portion of the membrane be left outside of the sinus, preventing intrusion of the entire membrane into the sinus during bone placement. second layer of the sinus graft materials. The second layer of the sinus graft layered approach is the most abundant and consists of the allograft bone material. Many materials have been proposed in single or combination mixes, including mineralized and demineralized freeze-dried bone, beta-tricalcium phosphate, xenograft hydroxyapatite, and calcium carbonates, that is bioactive glass. In addition, more recent research has focused on combining traditional bone substitutes with bone growth factors. Each graft material used in the sinus graft technique presents a similar yet distinct biological approach to the healing process. What type of graft material? Autogenous bone for years has been considered the gold standard of grafting material. Tatum first developed and reported the use of autogenous bone for sinus grafts in the 1970s, and Boyne and James first published the information in 1980. In primates, Misch found the use of iliac crest or tailbone in sinus grafts produced bone slightly denser than typical in the region, as evidenced from histology sections harvested at the re-entry procedure. Similar findings have been observed during case series studies with patients undergoing sinus grafts with autologous bone from the iliac crest or intraoral donocytes. It is interesting to note that sinus grafts in the literature that have used 100% autogenous bones have lower success rates than sinus grafts with synthetic substitutes. Many additional studies have concluded that 100% autogenous bone results in less bone formation than a composite type of graft. Holman and colleagues showed that sinuses grafted with 100% xenograft compared with 100% autogenous exhibited greater healing and higher implant survival rates. Forum and colleagues reported that if 20% autogenous bone was added to other bone substitutes, a greater mean vital bone formation was found. Demineralized freeze-dried bone has been shown to be osteoinductive, which is capable of inducing undifferentiated mesenchymal cells to form osteoblasts. The mechanism for this process appears to relate to the bone morphogenic protein found primarily in the cortical bone. In animal and human studies, DFDB allograft powder used alone in sinus graft did not provide satisfactory results. Bone was present but not in sufficient volume as the graft material originally placed. Speculation exists that the material resorbs more rapidly than the bone formation process, resulting in less bone formation. In addition, studies have shown that DFDB, when placed into an area of low oxygen tension, hypoxic or hypercellular tissue, results in fibrous or cartilage tissue rather than bone. Other authors have observed similar conclusions on the poor performance of DFDB used alone in animal and human studies. At the Sinus Graft Consensus Conference, high success rate were reported for all materials and combinations, with the exception of DFDB when used alone. Mineralized freeze-dried bone allografts are an allogenic bone that does not undergo the demineralization process. FDBA has the same BMP content in its organic matrix. However, it does not have the same osteoinductive capability of DFDBA. FDBA has been shown to be a better scaffold, osteoconduction, than DFDBA, which allows for superior space maintenance. Eventually, osteoclasts break down the mineral content of FDBA until demineralization occurs, inducing new bone formation and a prolonged protein release. Kamak and colleagues examined mineralized and demineralized freeze-dried allograft used in sinus augmentation procedures and found no statistical significance between the two bone substitutes. A histomorphometric study by Fromm and colleagues at 26 to 32 weeks after grafting evaluated mineralized cancellous bone allograft and anorganic bovine bone material for sinus augmentation. Bilateral sinus grafts, one filled with MCBA and the other with ABBM, were compared. The average vital bone content of the MCBA was 28.25% compared with the ABBM of only 12.44%. Therefore, mineralized corticocancellous bone of approximately 250 to 1000 μm is advantageous for bone graft material because it fulfills space maintenance requirements and allows for cell migration. Implant insertion. A review of the literature by Del Fabro and colleagues notes success rates of implants placed at the same time as the graft have a survival rate of 92.17%, whereas a delayed implant insertion has a survival rate of 92.93%. The 5 to 10 mm of initial bone height in an SA3 posterior maxilla, the cortical bone on the residual crest, and the cortical-like bone on the original antral floor may stabilize an implant that is inserted at the time of the graft and permit its rigid fixation. Therefore, when the conditions are ideal for the SA3 sinus graft, the implant may be inserted at the same appointment. When inserting implants into an SA3 sinus graft, the sinus should always be completely filled prior to implant placement. Attempting to graft after implant insertion is very difficult and will lead to warts. When preparing the osteotomy into the grafted sinus, a finger rest should be maintained so that the control of the handpiece is maintained upon perforation into the sinus. Care should be exercised to not extend the osteotomy into the grafted material. This will result in dispersion of the graft material. Penetration through the inferior floor should only be approximately 1 mm, as there will be no resistance from the graft material when placing the implant. In most cases, the osteotomy will be underprepared to allow for osteodensification of D4 bone. Implant placement is more accurate when inserted with a handpiece. The advantage of the SA3 technique is the decreased treatment time because the implant and sinus graft are completed at the same time. In addition, there exist several disadvantages of immediate implant placement compared with delayed implant placement, that is SA4 approach. 1. The individual rate of healing of the graft may be assessed during the healing period while the implant osteotomy is being prepared and the implant inserted. The healing time for the implant is no longer arbitrary, but it is more patient-specific. 2. Under ideal conditions, post-operative sinus graft infections occur in approximately 3% to 5% of the patients, which is greater than the percentage of implant placement surgery or intraoral only bone grafts. If the sinus graft becomes infected with an implant in place, then a bacterial smear layer may develop on the implant and make future bone contact with the implant less predictable. The infection is also more difficult to treat when the implants are in place and may result in greater resorption of the graft as a consequence. If the infection cannot be adequately treated, then the graft and implant must be removed. Therefore, a decreased risk of losing the graft and implant exists if a post-operative infection occurs with a delayed implant insertion. Some reports in the literature indicate a slightly higher failure rate of implants when inserted simultaneously compared with a delayed approach. 3. Blood vessels within the graft are required to form and remodel bone. An implant in the middle of the sinus graft does not provide a source of blood vessels. It may even impair the vascular supply. 4. Bone width augmentation may be indicated in conjunction with sinus grafts to restore proper maxillomandibular ridge relationships and or increase the implant diameter in the molar region. Augmentation may be performed simultaneously with the sinus graft. As a result, larger diameter implants may be placed with the delayed technique. 5. The bone in the sinus graft is denser with the delayed implant placement. As such, implant angulation and position may be improved because it is not dictated by existing anatomic limitations at the time of the sinus graft. 6. The clinician may access the sinus graft before implant insertion. On occasion, the sinus graft underfills a region, and the lack of awareness of the condition during implant insertion at the same time results in an implant placed in the sinus proper rather than at the graft site. 7. On re-entry to a sinus graft, it is not unusual to observe a crater-like formation in the center of the lateral access window with soft tissue invagination. If the implant is already in place, then it may be difficult to remove the soft tissue and assess its precise extent. When soft tissue is present at a delayed implant insertion, the region is curated and replaced with a bone graft before implant placement. The healing time of the implant is related to the developing bone assessed at the delayed surgery, not an arbitrary period that may be, on occasion, too brief. Membranes. After implant placement, a thin layer of graft material may be veneered over the lateral access opening. A resorbable membrane, example collat tape, is then placed over the lateral access window. A membrane will delay the invasion of fibrous tissue into the graft and will enhance the repair of the lateral bony wall. A non-resorbable membrane should not be used because re-entry would be required and the possibility of post-operative sinus infection will increase. A bacterial smear layer may accumulate in the non-resorbable material and contribute to the infection process. Rarely will a resorbable membrane become infected. Subantral option 4, sinus graft healing and extended delay of implant insertion. In the fourth option of implant treatment of the posterior maxilla, SA4, the SA region for future endosteal implant insertion is first augmented, then after sufficient healing, implant placement is completed. This option is indicated when less than 5 mm remains between the residual crust of bone and the floor of the maxillary sinus. In addition, if an SA3 approach is warranted because only 5 mm of bone is present, but pathology is present, it is often advantageous to complete an SA4 technique. The SA4 corresponds to a larger antrum and minimal host bone on the lateral, anterior, and distal regions of the graft because the antrum generally has expanded more aggressively into these regions. The inadequate vertical bone in these conditions decreases the predictable placement of an implant at the same time of the sinus graft, and less recipient bone exists to act as a vascular bed for the graft. In addition, in most cases, less autologous bone exists in the tuberosity for harvesting, and fewer septa or webs will exist in the sinus, and typically exhibit longer mesiodistal and wider lateromedial dimensions. Therefore, the fewer bony walls, less favorable vascular bed, minimal local autologous bone, and larger graft volume all mandate a longer healing period and slightly altered surgical approach. Sinus graft post-operative instructions. 1. Do not blow your nose. 2. Do not smoke or use smokeless tobacco. 3. Do not take in liquids through a straw. 4. Do not lift or pull on lip to look at sutures or stitches. 5. If you must sneeze, then do so with your mouth open to avoid any unnecessary pressure on the sinus area. 6. Take your medication as directed. 7. You may be aware of small granules in your mouth for 2 to 3 days after surgery. 8. Bleeding from the nostril may be present for the first 24 hours after surgery. Intraoperative complications related to sinus graft surgery. Membrane perforations. The most common complication during sinus graft surgery is tearing or creation of an opening in the sinus membrane. This has several causes, which include a pre-existing perforation, tearing during scoring of the lateral window, existing or previous pathologic condition, and elevation of the membrane from the bony walls. According to studies, membrane perforations occur about 10% to 34% of the time. It has been reported with a higher frequency in smokers. If membrane perforation occurs more often than this, then the clinician should give consideration to alter or re-evaluate the surgical technique used in sinus grafting. Sinus membrane perforation usually does not affect the sinus graft. However, in a report of the Sinus Consensus Conference analysis of failed sinus graft found 48%, that is 79 of 164 failures, were attributed to sinus membrane perforations. In an endoscopic evaluation after sinus grafts, macrolaceration of the sinus membrane resulted in a typical sinusitis appearance even when clinical conditions of infection were not present. Once the tear or perforation is identified, the continuation of the sinus elevation procedure is modified. The sinus membrane should be elevated off the bony walls of the antrum despite the mucosal tear. If a portion of the membrane is not elevated away from the sinus wall, then the graft material will be placed on top of the membrane, preventing the bone graft from incorporating with the bony wall. The perforation of the sinus membrane should be sealed to prevent contamination of the graft from the mucus and contents of the sinus proper and to prevent the graft material from extruding into sinus proper. When graft materials enter the sinus proper, they may become sources of infection or may migrate and course of the ostium to the nasal cavity and create an environment for an infection. Numerous studies have shown a very low probability of sinus infections after perforations in the sinus membrane. Jensen and colleagues reported that graft maturation occurred and no sinus infections were observed despite a 35% incidence of sinus perforation during the procedure in 98 patients. The surgical correction of a small perforation is initiated by elevating the sinus mucosal regions distal from the opening. Once the tissues are elevated away from the opening, the membrane elevation with the sinus curate should approach the tear from all sides so that the torn region may be elevated without increasing the opening size. The antral membrane elevation technique decreases the overall size of the antrum, thus folding the membrane over on itself and resulting in closure of the perforation. A piece of resorbable collagen membrane, example collared tape, is placed over the opening to ensure continuity of the sinus mucosa before the sinus bone graft is placed. The collagen will stick to the membrane and seal the SA space from the sinus proper. If the sinus membrane tear is larger than 6 mm and cannot be closed off with the circumellevation approach, then a resorbable collagen membrane with a longer resorption cycle, example Granovix or Biament, may be used to seal the opening. The remaining sinus mucosa is first elevated as described previously. A piece of collagen matrix is cut to cover the sinus tear opening and overlap the margins more than 5 mm. It should be noted that when a sinus tear occurs, it is sealed with a dry collagen membrane so that it may be rotated into the lateral axis opening, gently lifted to the mucosal tissue around the opening, and allowed to stick to the mucosa. Once the opening is sealed, the sinus graft procedure may be completed in routine fashion. However, care should be taken when packing the sinus with graft material. After a perforation, the graft is easily pushed through the collagen-sealed opening and into the sinus proper. The graft material is then gently inserted and pushed toward the sinus floor and sides but not toward the top of the graft. A sinus perforation may cause an increased risk of short-term complications. Oroantral fistulae. Oroantral fistulae may develop post-operatively, especially if the patient has a history of past sinus pathology or infection. Small oroantral fistulae, that is less than 5 mm, usually will close spontaneously after treatment with systemic antibiotic drugs and daily rinses with chlorhexidine. However, larger fistulae, that is greater than 5 mm, will normally require additional surgical intervention. Larger fistulae are associated with an epithelialized tract, which is the result of the fusion of the sinus membrane mucosa to the oral epithelium. When this occurs, patient will most likely complain of fluids entering the nasal cavity on eating or drinking. Caution should be exercised in using the Valsalva maneuver, that is nose blowing test, to confirm the presence of an oroantral fistula at the time of the surgery. The patient is asked to pinch their nostrils together to occlude the nose. The patient blows gently to see if air escapes into the oral cavity via the sinus. This is not recommended because this test may create an opening or make a small opening larger. The Valsalva maneuver may be used postoperatively to diagnose a suspected communication. Management. Closure of oroantral fistulae can be accomplished by using broad-based lingual or facially rotated flaps. Buccal flaps to close the fistulae may be more difficult after a sinus graft because of the location of the graft site. In addition, the buccal tissue is very thin, and rotated or expanded buccal flaps usually result in loss of vestibular depth. Before the initiation of the flap design, the soft tissue around the fistula is excised and the sinus flow curative to ensure direct bone contact. Moving on to Chapter 38, Intraoral Autogenous Bone Grafting. History of autogenous bone grafts. The use of iliac crest autologous bone blocks with osteo-integrated implants was initially described by Brainmark et al. And is now an accepted procedure in the oral and maxillofacial rehabilitation. Although the iliac crest is often used in oral and maxillofacial reconstruction with dental implants, there are many disadvantages related to harvesting bone from the ilium. The surgery is far more aggressive than intraoral techniques, and it must be performed in a hospital setting under general anesthesia. This ultimately will increase patient cost, and complications from the surgery, such as neurosensory and gait disturbances, are increased. As an alternative to the iliac crest, there are multiple autogenous donor graft sites that originate intraorally. These include the mandibular symphysis, mandibular ramus, and maxillary tuberosity. In the literature, the mandibular symphysis was one of the first intraoral donor sites reported. Early case reports described its use in the repair of intraoral birth defects such as cleft palates. In 1992, Misch et al. Expanded the indications for the use of mandibular symphysis and ramus block bone grafts with endosteal dental implants. In the repair of localized alveolar defects of the jaws, bone grafts harvested from the intraoral sites known to offer several advantages. The main advantage of intraoral versus extraoral donor grafts is the convenient surgical access and lower morbidity. The proximity of donor and recipient sites can reduce operative and anesthesia time, making them ideal for outpatient implant surgery. In addition, patients report minimal donor site discomfort compared with bone harvested from the iliac crest or other extraoral donor sites. Bone harvested from the maxillofacial region appears to have inherent biological advantages in bone graft augmentation. This may be attributed to the embryologic origin of the donor bone. The majority of bones in the human skeleton are of endochondral origin, that is, from a cartilaginous precursor. With the exception of alveolar bone and mandibular condyles, the maxilla and body of the mandible develop intramembranously. Ramus graft. Indications: horizontal and vertical ridge augmentation, 3 to 4 tooth edentulous sites, maximum size 3 to 5 cm. Advantages: allows for largest average surface area of intraoral grafts, no aesthetic concerns, decreased pain and discomfort, decreased chance of incision dehiscence. Disadvantages: inferior alveolar and lingual nerve injury, access may be difficult, and trismus. Tuberosity bone graft. Indications: circuit grafting, sinus augmentation, small bony defects, approximately 1 to 3 mm. Advantages: allows for largest average surface area of intraoral grafts, no aesthetic concerns, decreased pain and discomfort, decreased chance of incision dehiscence. Disadvantages: entry into maxillary sinus, oral antral fistula, bleeding posterior superior alveolar, pterygoid plexus, hematoma. Summary: autologous bone grafts are the only type of graft material that heals via osteogenesis, osteoinduction, and osteoconduction. Bone harvested from the maxillofacial region offers several advantages in the reconstruction of the residual ridge for implant placement. Intraoral donor sites require only one operational field, which decreases the surgical and anesthetic time. Larger block bone grafts may be harvested from the mandibular symphysis, body, or ramus area. Particulate autograft may be harvested from the maxillary tuberosity, extraosseous tori, ridge osteoplasty, extraction sites, implant osteotomy, and bone collection devices. These grafts require a short healing period and exhibit minimal resorption while maintaining their dense quality. The morbidity of graft harvest is low, and complications usually result in only temporary debilitation. The use of these techniques allows the placement of implants in ideal position for optimal aesthetics and functional support. Let us now proceed with Chapter 39, Extraoral Bone Grafting for Implant Reconstruction. Introduction. The pool of patients that are eligible for dental implant reconstruction has expanded widely since brain-mouth research first hit the world of dentistry in the early 1980s. Extensive research in bone biology, coupled with newer and proven bone grafting techniques, leaves almost no patient outside the boundaries of eligible recipients. This includes patients with large bony defects resulting from trauma, resection from pathologic lesions, and congenital deformities, which would be classified as Division E in the Misch classification of available bone and prosthetic options. Procedures designed to provide large quantities of bone harvested from outside of the facial region that were previously used to only restore continuity and primitive function now are expected to reproduce vertical and horizontal dimensions for ideal placement of implant fixtures for the support of multiple prosthetic designs. These new demands on the implant surgeon make the evaluation of the recipient defect, both dimensions and biologic environment, as well as the appropriateness of the potential donor site bone quality, of paramount importance. For instance, loss of bone from treatment of neoplastic or other pathologic processes represents far greater reconstructive challenges than loss of bone from trauma or infection. Other factors important to deciding the type and quantity of bone graft required to be harvested for larger defects is the presence of systemic diseases and the possible exposure to therapeutic doses of ionizing radiation. Success rates of bone grafts in irradiated jaws have been found to be lower by significant amounts, as well as complication rates of 81.3%. The rich cellular components that make autogenous grafts the gold standard of implant-supported bone grafts, along with techniques such as hyperbaric oxygen treatment, platelet-rich plasma, and the use of engineered growth factors such as bone morphogenic protein, all act to combat and hopefully overcome any hostile environment to provide a healthy osseous base for the placement of dental implants. The four major anatomic areas for harvesting of free autogenous bone that will be discussed in this chapter include the cranium, the anterior and posterior iliac crest, and the tibial plateau. The necessity required for the proverbial mother of these inventive techniques was primarily provided by the multiple facial injuries sustained by American and German soldiers during World War I and II. Iliac crest bone graft. The ilium is historically the most popular donor site for facial bone grafting because of the high volume of cancellous and cortical bone. The corticocancellous block harvested from the ilium provides the best of both worlds in bone grafting by combining the high cellular transfer of the cancellous matrix with the BMP-rich structural support of the cortical bone. The anterior ilium may yield up to 50 cc of bone for augmentation. This amount can reconstruct a 5 cm segmental defect of the mandible using the following equation. 1 cm requires 10 cc of bone. For the purpose of implant site preparation, this is usually sufficient. However, if larger division E deformities exist, then the posterior ilium may be used. The posterior iliac crest can be harvested for donor bone when more significant volumes are necessary for the grafting of a facial defect. The posterior iliac crest provides the same quality and ratio of cancellous and cortical bone, but in quantities approaching 100 ml of cancellous bone and a maximum of 5 × 5 cm cortical block. Ilium graft advantages and indications. 1. Cortical and cancellous bone in blocks and as free cancellous grafts. 2. Can reconstruct large alveolar defects up to 5 cm anterior to 12 cm posterior in length. 3. Large sinus augmentations and horizontal and vertical ridge augmentation. 4. Alveolar cleft reconstruction. Ilium graft. Disadvantages and cautions. 1. Second site harvest and postoperative pain. 2. Contraindicated in metabolic bone disease, previous fracture site or osteomyelitis, or previous hip prosthesis. Tibial bone graft. The proximal tibial metaphysis provides an excellent source of cancellous bone. The quantity that may be harvested is close to or equal to that of anterior ilium. The tibial graft has a low complication rate and is technically easy to perform. Comparison of tibial versus iliac crest grafts in secondary alveolar cleft reconstruction showed similar bone densities at 6 months. Tibial bone grafts are most commonly used for maxillary sinus lift procedures and augmentation of existing bone for the placement of implant fixtures. The rather low morbidity and easy surgical access allows skeletally mature adults to have the surgery completed on an outpatient basis. Because of possible damage to developing epiphyseal growth plates, this procedure is not recommended for children or adolescents. However, several authors have reported the safe and successful use of these grafts for alveolar cleft grafting in children. As with the ilium grafting sites, it is recommended to avoid sites that have had previous surgery with orthopedic hardware or prosthetic joint replacements. It is also prudent to avoid using this procedure on patients that apply large amounts of force to the tibia on a repetitive basis, such as runners or other active athletes. The anterior wall of the tibial plateau was exposed and hemostasis obtained. With the use of a small round burr, a circular bone incision was made and the thin cortical cap removed. Then 24 cc of cancellous bone was curated out of the site and mixed with strips of platelet-rich fibrin and packed into the sinus floor blood. Enough supportive bone was available to place immediate implants at the time of surgery. Vascularized composite graft, the fibula. As mentioned previously, when the bed for a bone graft is compromised by radiation therapy, lack of blood supply, extensive length of the defect, or just the compromised medical condition of the patient, a vascularized composite graft may be indicated. These grafts differ from the free autogenous grafts because they do not depend on the recipient's local environment to aid in the regeneration and consolidation of new bone. These composite grafts bring their own blood supply with them and maintain normal physiologic function within all of the transferred tissues. This will include a certain amount of soft tissue that helps to cover and protect these bone grafts in compromised receptor sites. The downside of these grafts is the increased procedure time and the sometimes unavailable expertise of a microvascular surgeon. Technical complications include larger defects at the donor sites and the inability of the surgeon to construct a bony bed that is any different from the anatomic dimensions of the grafted bone. In the past, this bone stock, by providing excellent reconstruction of the continuity defect, did not always provide the best base for an implant-supported prosthesis. As the reconstructive surgeon and implantologist worked together over the years and realized the limitations of both, most of these problems have been resolved. These advances in cooperation between the surgeon and the implantologist is no better evidence than in the emergence of the computer-aided design or computer-aided manufacturing technology, producing three-dimensional models for both the harvest and the implant placement, which has decreased treatment time from months to days. We now arrive at the concluding chapter of this section, Chapter 40, the use of Botox and dermal fillers in oral implantology. The field of oral implantology is constantly changing because of the advances in technology and science. With a better understanding of the dynamic relationships of the soft tissues surrounding the orofacial complex, the use of injectable botulinum toxins and dermal fillers has become an integral part of dentistry. With respect to oral implantology, dental implant clinicians are in a unique position to evaluate and treat patients with these products. These pharmacologic agents may be used to control parafunctional habits, help restore function, relieve pain, and supplement facial aesthetics in conjunction with implant prosthetic procedures. Currently, the two most popular treatments used in conjunction with oral implantology procedures include the use of injectable neurotoxins, BTX, and injectable dermal fillers, hyaluronic acid. Botulinum toxin type A uses in implant dentistry. 1. Parafunctional habits. 2. Temporomandibular joint syndrome or temporomandibular dysfunction. 3. Excessive tissue display or gummy smile. Parafunctional habits. Masseter muscle hyperactivity. A common sequelae of patients with parafunction is masseter hypertrophy. The masseter muscle is one of the primary muscles of mastication. When the masseter muscle is hyperactive or overused, the facial appearance often enlarges and results in a negative cosmetic impact with altered facial lines. Muscle function is also altered, which results in excessive force being placed on the teeth or implant. Studies have shown a significant reduction in masseter muscle volume with an average reduction in mass of 22% and up to approximately 35% reduction after the continued use of BTX-A. Botox technique. Injection into the masseter muscle for the treatment of masseter hypertrophy was first discussed by von Linder et al. They suggested injections in the zygomatic arch and the mandibular angle. However, this method revealed a higher risk of injection into the parotid gland, which led to significant complications. Hu et al. Determined a safe zone for injection sites into the masseter muscle. They recommended the safest entry point to be in the central compartment of the masseter muscle as to avoid injections into the parotid gland and the mandibular branch of the facial nerve. The parotid gland is located superficial and at the posterior margin of the muscle. Branches of the facial nerve also run superficial to the muscle. The delineation of the safe zone is a line drawn from the lower A to the angle of the mouth, superior margin. The anterior extent is determined by palpation and the posterior extent is the posterior angle of the mandible. The inferior border is delineated by the inferior border of the mandible. Conclusion. The use of Botox and dermal fillers have been shown through the literature to be valuable adjuncts in implant dentistry. These pharmacologic agents are successful in treating many facial and maxillofacial musculature dysfunctions as they provide an overall conservative, minimally invasive treatment approach. Most notably, Botox may be indicated for the treatment of parafunctional habits that may be detrimental to the overall dental implant success. In addition, the use of Botox in the treatment of various temporomandibular joint syndrome or temporomandibular dysfunction disorders and excessive tissue display have also been shown successful. The use of dermal fillers have become popular for facial and cheek soft tissue augmentation as well as for the treatment of angular cheilitis. With respect to dental implants, papilla loss leading to the formation of black triangles may be treated with dermal fillers leading to the reversal of the open spaces. Therefore, with the advances of technology and science, the use of Botox products as well as dermal fillers are becoming more popular and have become a mainstay in implant dentistry. Having explored these concepts, we draw this insightful section to a close. Thank you.